Great. So good evening. I want to welcome everyone to our health equity webinar. My name is Fahd Khan, and I have the pleasure of being the president of the Santa Clara County Medical Association this year. So I am a neurosurgeon in private practice in San Jose and have privileges at Good Samaritan Hospital, El Camino Hospital, and O'Connor Hospital. So just a little bit of background. Founded in 1876, the Santa Clara County Medical Association is a 501c6 professional organization based here in Santa Clara County and headquartered in San Jose. We represent over 4,800 physicians across all specialties and career stages. SCCMA supports its members through advocacy, educational programs, wellness initiatives, practice management resources, and collaborates on policy at all levels. Today, we are presenting an educational webinar. For the first time in our history, we had a public health intern, Theodore Bussell, who joined us for a few weeks over the summer to help extend our understanding of health equity in Santa Clara County. And that's how today's webinar came into existence. So also joining me today are Dr. Tony Iton and Dr. Corneliu Delogramatic. So I want to thank them. So I thought I would maybe kick off the webinar with just a brief introduction about health equity just in general. So when we think about what is health equity, it's that everyone has a fair and just opportunity to be healthy. It requires really removing barriers such as poverty, discrimination, housing, education, and healthcare access. But equity is not the same as equality. It means meeting people's needs fairly. So I think this graphic on the right lower part really explains, for me, the whole process really well. And this is used pretty commonly. When we talk about equality, everyone's kind of at the same level, but that doesn't mean it's really fair to everybody. There's a lack of equity there. And the illustration on the right shows what it really means to be having equity. And why does this matter in Santa Clara County? Well, we do know that in our county, life expectancy can vary by neighborhood. Obviously, in California, especially in our area, high cost of living affects access to care, and chronic disease rates are higher in underserved groups. There's language and cultural barriers as well, especially in our county, which can limit access to services. So why does it matter? Well, again, everybody has a fair and just opportunity to be as healthy as possible. I don't think anybody will disagree with that. But it's important to remove barriers such as poverty, discrimination, lack of access to good jobs, education, housing, and healthcare. So health equity is essential for stronger, healthier communities in Santa Clara County. So with that in mind, I wanted to introduce our next speaker. That's going to be Theodore Bussell. He is a first-year graduate student at the University of California, Berkeley, in the Masters of Public Health program with a concentration in health and social behavior. He hopes to combine this education with his background in anthropology, clinical research, and tobacco cessation counseling to better serve the needs of marginalized groups through policy change and community-based solutions. So I'm going to stop sharing. And Theo, the floor is yours.
Perfect. Thank you so much for that introduction, Dr. Khan. I really appreciate it. Can everyone see my screen all right? Great. Okay. So let's move here. Oh. Oh, it's not moving. Hold on. Okay, I'll try that again. All right. So, looking at the agenda for today, Dr. Khan has already kind of gone over what health equity is, so I'll skip through that pretty quickly. But I did want to go over some general demographics of Santa Clara County, discuss some key insights from the interview series and literature review that I did with SCCMA, We're going to outline some best practices for physician members, and then also discuss some next steps that are available. And then, of course, we've got our panelists speaking to share their own experiences in the health equity space. So health equity, I have the same similar demographic or graphic there. This definition here by the World Health Organization, I feel is very useful to understand that there are a lot of different factors that really define inequality and ultimately what resources people need. And so our goal with my project at Santa Clara County Medical Association was to examine the county's health priorities through an equity lens. And the first step to this project was to look at different demographics of the county. So we have a population of 1.9 million people, and then looking at census data, the county is very clearly racially diverse, with a majority of Asian and white inhabitants, but also important to note is that with regard to ethnicity, 1/4 of Santa Clara County residents are Hispanic or Latino. The county also has a very high immigrant population, with 41% of the county's inhabitants being foreign-born. This might be a little bit hard to visualize, but compared to the rest of the state, only 27% of inhabitants are foreign-born. So this really indicates that immigration rights are a highly relevant issue for members of Santa Clara County. And then alongside this issue, we see that more than 50% of county residents speak a language other than English at home. And then here again, we can see that's very different compared to California. So if that ratio is so high, what are the languages that residents speak? It turns out there's actually more than 100 languages other than English spoken at home. This one is just a list of the top 10 most common languages other than English in the county, but you can see quite a wide variety of languages. So things like Spanish, Vietnamese, Tagalog, Hindi, Russian, Farsi. And with those brief demographics data overview in mind, we can just jump right into the interview series here, which was a series of 30-minute interviews using an adapted data review structure from the Institute for Healthcare Improvement. And those included departments within Santa Clara County, Board of Supervisors Office, El Camino Health System, Stanford Health, PAMF, Valley Medical Center, and we had 15 total contacts from all of these different areas. And that allowed us to get a multi-level understanding of different health priorities, which really helped guide the literature review. And during the interviews, we also discussed various challenges that interviewees encountered in their work. So the most common challenges across the board were stakeholder buy-in, challenging internal biases, a lack of data for efforts, and then different siloed approaches. So some interviewees were able to theorize different solutions for these issues, including increased advocacy efforts, broader organizational shifts here, such as implementing organizational policies to guide cultural shifts and support internal work, investing in equity-centered data collection and analysis to inform decision-making, and fostering collaboration by creating roles for facilitators with cross-disciplinary expertise so that they could prioritize communication and connection between different groups. And all of this helped shape the direction of the literature review. And our key findings for the literature review were the importance of culturally relevant care, access to basic needs, environmental concerns, specific health conditions within the county, which were prediabetes and diabetes, and then financial return on investment. Those findings were supported by two different theoretical models, the first of which is the social ecological model of health behavior. This model really helps to operationalize the influence of our immediate and wider environment on our health. So, for example, non-nutritive food choices, excess ingesting of fast food or not cooking healthy foods, those are influenced by environmental constraints like access to income, transportation, grocery stores, free time, and it's not just a lack of knowledge or discipline. And in addition to this, we wanted to zoom out even further using the planetary health model. This extends the previous social ecological model to the global level, really. So it zooms out, and it helps to visualize how human health and ecosystem health are deeply intertwined and uh, deeply intertwined and dependent on one another. And so using this model, it's easier to kind of make the assertion that things like wildfire smoke and air quality are health determinants for wide swaths of people. And so we can go using these models into the insights of our literature review. So we found that the areas of culturally relevant care were critical for patients in the county. And in the context of physicians, education on cultural competency and humility was linked to stronger patient-physician relationships, which is a benefit to their health outcomes. Similarly, language access through medical translation services, either in person or over the phone, is seen to have drastic increases in health outcomes, improvements in health outcomes. And as we mentioned earlier, over 50% of residents in the county speak a language other than English at home. And so having increased access to language is vitally important for this county. Our next focus on the importance of access to basic needs includes food, housing, water, and transportation. In Santa Clara County, 133,000 residents receive CalFresh benefits, and 1 in 4 residents of the county receive Medicaid insurance. So basic needs access is often viewed as a social services issue, but healthcare providers can function as vital advocates and connectors for their patients. So for example, physician advocate groups can support things like SNAP or CalFresh expansion, or they can provide community referrals to local programs during their patient contact. For our environmental concerns, our big 3 were water quality, air quality, and access to green space. In order to condense this down, because I could kind of go on about that, I wanted to give you all a bit of a bird's eye view of the situation. So we'll look at some GIS maps of the county to highlight these issues a little bit more effectively. So this is Santa Clara County, and the following data was from the Trust for Public Land. This is a map, a chart mapping out access to green space in the form of public parks. So the green mostly on the edges is a park with public access, and the darker purple sections are area of high priority for potential park development. Looking at this map and keeping it in mind, this is a map for risk of pollution-based respiratory hazards. The dark brown is high risk and the green is very low risk. But as you can see, looking at that map, in the middle of the very high section, where there were very few parks, are multiple freeways intersecting in that middle of San Jose there. This map is a visualization of urban heat islands. Urban heat islands are metropolitan areas with significantly higher than average temperatures than their surrounding rural areas. Those are primarily caused by urban construction materials like concrete and asphalt, which absorb more heat than natural surfaces. And this increased heat is pretty dangerous for vulnerable populations that are living in the area. So elderly people, disabled people, unhoused populations are all more likely to be hospitalized by heat-related adverse events. And those dark orange areas are extremely high temperature compared to rural areas. This map, as you can see, is a map of low-income households in the county. It looks very similar to the air pollution risk hazard map, but it looks almost exactly the same as our limited English proficiency map. And so looking at these different maps, I hope that it's a lot easier to see that environmental concerns that we have as a county impact low-income marginalized groups, and efforts to improve health equity within the county and for those groups require us to take the environment into account. Now, the specific health concerns were prediabetes and diabetes, which were shown to be positively benefited by access to community food programs. One of the caveats to that is that food access programs do need to have resources to purchase foods that are outside of starchy pantry staples, so rice, bread, flour, etc. Having access to green leafy vegetables is better than having access to significant amounts of starch. We also found that the highest burden of prediabetes and diabetes was among low-income and Latino residents. And we are fortunate enough to have this very recent data from Supervisor Arenas' recent project, the Latino Health Assessment. And then our focus on return on investment for the financial side of health equity we really wanted to talk about health equity is not just a social issue, it has economic merit as well, which is contrary to some popular belief that health equity is necessarily spending too much money. From this graphic, you can see that there are different benefits to economic stability on just the financial side, but also improving health equity within the county increases access to education, access to health and healthcare, improves the neighborhood and the built environment. All of these things help improve the health of a worker pool within the county that can then make money, spend money, improve the economy, and also have less of a financial burden on the healthcare system. So what are some best practices for improving health equity in your own work? You can start by committing to the principles of health equity. So the idea that different communities require different approaches and resources to improve their health, and understand that this is an ongoing commitment to improvement. You can perform an assessment of your own environment. So that's both your internal environment, your biases, and your external environment. What does your organization look like? See what areas can be improved, identify short and long-term goals that you can work to achieve, and find collaborators that can help you make the work easier, because we don't need to reinvent the wheel here. We want you to be able to continuously check in with the goals that you've set. So are you making progress? What's stopping you? How can you be helped? Who can help you? And really understand that health equity and your interventions need to be data informed and holistic, which also means that health equity needs to involve health providers, policymakers, and community organizations. So what are the next steps that are available to you as physician members? You can advocate for social services like that increase to SNAP. You can advocate for improved environmental regulations that can improve community health. The Santa Clara County Medical Association has an external affairs committee to participate in these efforts. And if you're interested in joining that committee, you can email Emily at SCCMA.org. You can also talk to your institutional leadership about how to improve goals like this within your own healthcare center. You can connect patients directly with services to meeting basic needs. So that's access to SNAP, housing programs, and different social services that you may be aware of or may want more information about. And then you can also partner with community organizations that are working to achieve similar goals. All of this information is also available as supplemental material to this webinar. And I do want to state that we are in a county with a lot of different challenges and struggles that are ongoing, but it's also important to recognize and acknowledge how fortunate we are to also be in a county that is so committed to health equity and improving the lives of residents. So, thank you. I'll turn this back to Dr. Khan.
Great. All right. Theo, thanks for a great, awesome presentation. We really appreciate the summer you spent with us and the work that you've done here. And we hope it sort of enlightens the rest of the county on this really, really important issue. So thanks again and great work. Next, I have the pleasure of introducing Dr. Anthony Iton. So he is the Chief Executive Officer at the Health Trust. Dr. Anthony Tony Iton is a physician, attorney, public health leader, and nationally recognized advocate for health equity. Over a career spanning more than 30 years, Dr. Iton has tackled systemic barriers to health and championed community-led solutions to address health inequalities. At the California Endowment, he served as Senior Vice President for Healthy Communities, leading the landmark $1 billion 10-year Building Healthy Communities initiative, one of the largest philanthropic efforts of its kind in the nation. His visionary leadership focused on empowering marginalized communities, shifting policy systems, and reimagining public health practices. Previously, Dr. Iton served as Director and Health Officer for the Alameda County Public Health Department. There, he pioneered innovative strategies to address social determinants of health and co-authored research demonstrating how zip codes predict life expectancy more than genetic codes. Dr. Iton holds an MD from Johns Hopkins University, a JD and MPH from UC Berkeley, and a bachelor's in neurophysiology from McGill University. He is a lecturer of health policy and management at the UC Berkeley School of Public Health and serves on the board of national organizations focused on health equity, including Public Health Institute and Prevention Institute. So Dr. Iton, thank you very much for joining us. We're really privileged and lucky to have you with us today.
So, thank you, Dr. Khan, and thank you, Theo. Theo was in my class last semester, so it's really quite a privilege and treat to see him just shining here. I'm going to share just a few slides and then talk through them relatively quickly. And then I am going to, okay, where are my slides? Let's make sure I can find them. Excuse me for 1 second. And okay, so let's put those up. It is it's always a privilege to talk about health equity. Let's see, is that, oh, there it is. Okay, good. And let's get to the first slide. Oops. There we go. Okay, I'm hoping you can see these slides. Okay, great. So I love living in the Bay Area. And living in the Bay Area means that you get to work with and scheme with some incredibly smart people, like the people on this webinar and like many of the people I imagine in the audience. I had the privilege of working in Alameda County as the health officer and health director for a number of years, and then working statewide on health equity issues at the state's largest health foundation, and now have the distinct privilege of being the CEO of the Health Trust, which is San Jose based and focused on the Silicon Valley, Santa Clara County, and San Benito counties. And I want to take you through just a quick story to tell you about how this work has evolved for me. First, there's some big lessons in the work. And when I went to medical school, we were basically taught to think about health as behavioral, whether people smoke, they drink, they drive without seatbelts, have sex without condoms, that they were basically people whose behaviors needed to be changed. And that's one paradigm of health. There's a second paradigm, which is health is largely transactional. It's about the quality of healthcare services you get, how good your doctor is, whether you have access to exceptional technology, MRIs, CTs, PET scans, pharmaceutical wonder drugs. That these things are the things that shape health. And there's a third paradigm that is really that health is about your genes. And some people have, basically were dealt a good hand of genes, and other people were dealt a bad hand of genes. And for those who got bad genes, you essentially had to work on intensifying medical services to try to improve their health outcomes and changing their behaviors. And all of these paradigms are true. They're absolutely true when you study them at the patient and doctor level, the individual level. They're largely individual frames, but they don't explain the macro population trends we see in health in the United States. And to explain those, I believe in telling you what I'm going to conclude, you have to recognize that health is fundamentally political. When I say political, it's a small p political. One definition of politics is simply the struggle over the allocation of limited and precious social goods. And as Theo laid out in his presentation with maps and overlays, some of those scarce and precious social goods may be things like a grocery store in your neighborhood, or a park, or a bike lane, or potable water, or reliable housing that's not overcrowded and poor health. These things are health protective resources, and they're not allocated in an equitable way in this society. And the way that they're allocated is through political processes. And communities that don't have a lot of power end up struggling to access these resources. So it means that to create health equity, power matters. And one of the modalities of improving health equity is building social, political, and economic power and a critical mass of people living in those very places that are struggling to access health resources. And that's what I did for over a decade at the California Endowment. And let me just explain to you some of the thinking behind it. As was mentioned, I was credited with coming up with this notion that when it comes to your health in the United States, does your zip code matter more than your genetic code? I don't know if I was the first person to say it, but I certainly said it a lot and did a lot of research behind that. This is some of that research. This is just a sort of a picture of sort of the inner Bay Area. Hopefully most of you recognize San Francisco there and the East Bay to the right. And I was the health officer and health director in Alameda County, which is shaped like a boot, sits on top of Santa Clara County. And when you're the health officer, you're the registrar of all births and deaths, and those are vital events. There are about 20,000 births in Alameda County every year and about 10,000 deaths, and each of those gets a certificate. And those certificates tell you a lot. There's a lot of information in a death certificate. It tells you what the person died of, as you know, because I'm sure many of you have filled them out. It tells you how old the person was when they died. It tells you their race, ethnicity. It tells you where they lived. And it tells you a lot of other things. It tells you about their education. It tells you about their employment, if it's completed correctly. But these 4 data points can tell you a lot about patterns of death in a community. And so in Alameda County, we took over 500,000 death certificates and we created a database, and then we mapped death across the county at the census tract level. And so this is Alameda County divided into census tracts. And there are about 10,000 people in each census tract. There are about 150 census tracts in Alameda County. And we calculated on average how long somebody could expect to live in their census tract or their neighborhood. So in those green areas, people can expect to live routinely above 80 years. In the red areas, people can only expect to live to about 74 years. And in between, in the yellow areas, it's between 74 and 80 years. And you see, when you look at this map, it's not rocket science, you see these concentrated areas of premature death. And they're concentrated in Alameda County and in the flatlands of Berkeley, flatlands of Oakland, and along the Interstate 880 corridor. And this map got a lot of attention. People were very surprised and confused by it that we had these hot spots of premature death in Alameda County. It got so much attention, it ended up on the front page of the San Francisco Chronicle. And it stimulated a lot of policy conversation about why you have such overt inequities in Alameda County in areas that are so discrete and dramatic. And, we thought, well, yes, you see that in Alameda County, but it's not unique to Alameda County. You see it in Santa Clara County as well. This is a map that's more at the city level, looking at Santa Clara County and showing that the cities of Palo Alto and Cupertino have life expectancies in the mid 80s, whereas Gilroy and Morgan Hill are down in the mid 70s. So you're talking at least a 10-year life expectancy difference there. If you go down to the census tract level, you can see neighborhoods with much lower life expectancies than even the full city of Gilroy. We decided we wanted to understand how widespread this phenomenon was, so we took our little map and we decided to go work with some other health departments around the country. We went to Baltimore, Maryland, where I went to medical school, and they have neighborhoods in Baltimore with life expectancies of 58 years and other neighborhoods with life expectancies of 90 years. So significant differences across the city of Baltimore. Similar impact in Cleveland. This is Cuyahoga County. Cleveland has a neighborhood in East Cleveland called Huff with a life expectancy of 61 years, and 1.8 miles down the road, you have a neighborhood called Lyndhurst with a life expectancy of 88.5 years. So dramatic differences there. We saw differences in New York City, did the same analysis in Washington State, in Los Angeles, in Minneapolis, St. Paul, in Boston and Philadelphia and San Antonio and Denver, Cincinnati, St. Louis, Chicago, everywhere we looked, we found life expectancy differences on the order of 20, 25, 30 plus years in the same city. Now, I want to take you back to the first slide that I showed you, which was essentially around the common paradigms that we use to explain differences in health outcomes. And you cannot apply those paradigms to this phenomenon. You can't ascribe this to differences in health behaviors. You can't ascribe it to differences in genetics. And you can't, surprisingly, ascribe it to differences in access to healthcare. All three of those things are insufficient explainers for this phenomena. They don't explain a 30-year life expectancy difference between two neighborhoods in the same city. What does explain it is a history and legacy of segregation and separation of people from opportunity, i.e., a political explanation for these differences. I'm going to show you some international comparisons in a second that show you that this is a uniquely American phenomenon. So the other thing you can do if you're a data nerd like myself is you can take the life expectancy map on the top left and correlate it with poverty at the census tract level on the bottom right, and you end up with this simple bivariate correlation, which you will remember from medical school. Correlation is not causation, but you can see patterns. You've got life expectancy on the y-axis. You've got poverty on the x-axis. So as you move from left to right here, each of those blue dots is a neighborhood in Alameda County. And as you move from left to right, you're moving from relatively wealthy neighborhoods to relatively poor neighborhoods, and you see life expectancy is correspondingly shorter. There's a cost to living in a poor neighborhood in Alameda County, and it's not just Alameda County because we did the whole San Francisco Bay Area. There's a cost to living in a poor neighborhood, and it's measured in a shortened life. This is a death tax that mostly low-income people pay living in low-income, resource-deprived neighborhoods. There's a measurable tax on the length of their lives as a consequence of the social structures that we have created for low-income people in this country. And you'll note, this is the entire state of California, you'll note that this is a gradient. It's not like you have rich people and then you have poor people. You have people in the middle who are also paying a tax, but it's less of a tax than much lower income people, but it's a greater tax than relatively high income people. We can talk about, if anything comes up in the Q&A, how our wealthiest compare to the wealthiest in other countries, and it's not good. Even our wealthiest pay a tax in terms of length of life in the United States because of the way we've laid out our society. I want to show you this quickly. This is to set up a comparison. These are California counties. It's reading from the top left, Alameda County, Los Angeles in the top middle, Orange County in the top right, Riverside in the middle left, San Bernardino in the middle, and San Diego in the right in the middle. And then the bottom left there is Santa Clara County. And this is that same analysis that I showed you before. This is just life expectancy correlated with household income. And you see as you move from left to right, you're moving from relatively wealthy neighborhoods to relatively poor neighborhoods. And you see a slope of that line. There's a cost to living in a poor neighborhood in California in these counties. And I just want you to focus on the slopes of these lines because I'm going to show you some lines from the equivalent in Canada next. That's Santa Clara County, just so you see. These are Canadian metropolitan areas, Calgary, Edmonton, Montreal, Ottawa, Toronto, Vancouver. And just look at the slopes of the lines in Canada. Same exact analysis. We worked with the Canadian Public Health Association to do this analysis. That's Canada. This is California. Just to make it simpler for you, we aggregated all the California counties up at the top, and we aggregated all the Canadian metropolitan areas at the bottom. And you don't have to be a rocket scientist to see that the cost of living in a poor neighborhood in Canada is not nearly equivalent to the cost that you have to pay to live in a poor neighborhood in the United States. There is a significant death tax in the United States that doesn't exist in more egalitarian societies like Canada. The other thing that you'll note, and we've seen this all over the world, is that the flatter the line is, the higher the overall line is. In other words, average life expectancy in Canada is significantly higher than the US. It's significantly higher than in California. So the more inequity you have in a society, the lower the overall life expectancy is for everybody, including wealthy people. It's hard to put a scattergram on the front page of the San Francisco Chronicle, so we monetized the slopes of those lines, and we ended up telling people that every additional $12,500 in household income in the Bay Area buys you a year of life. That's the cost of life in the San Francisco Bay Area. So we know through essentially decades of epidemiologic studies that healthcare is important, but it's woefully insufficient to actually shape life expectancy. It's closer to 90% of what influences your life expectancy happens outside the realm of doctors like myself and Dr. Khan. This is really shaped by the environments that we structure and the opportunities that we structure for people that they have to navigate on a day in, day out basis. I'm going to conclude quickly here with just a framework that we developed. It's an organization called the Bay Area Regional Health and Equities Initiative. We developed a framework really out of frustration that we felt that the tools that we had at our disposal were not up to the challenges that we were facing. They were mostly medical model tools. The medical model basically stays within that paradigm of behaviors, genes, and access to healthcare. And I don't want to denigrate it. It is absolutely essential when you're dealing with patients. You have to think about their behaviors and changing them. You have to think about their genetic profile, and you have to think about the kinds of access to care that they need, the pharmaceutical interventions that they need. That's a $4 trillion enterprise, and it's focused primarily on trying to reduce risk that can be discerned in a clinical encounter. The idea is to reduce the rate of disease or the severity of disease and injury to essentially reduce the likelihood of premature death. And the interventions are trying to change what people know, tinkering with their genes, which can increasingly, have some sort of impact, although it's highly expensive and still hasn't proven its real potential. And then facilitating access to healthcare and healthcare interventions. We argue that that's necessary but insufficient. You have to look upstream and think about the structural drivers of poor health that create this downstream cascade. And we believe that this country was formed on the basis of essentially white supremacy and other isms that structured inequity in the country throughout our institutions, our practices, our policies. And that created essentially the neighborhoods that we have to contend with now, where you have whole communities that are devoid of health protective resources. And so what we've argued is that health disparities live downstream, but health inequities live upstream. You can take the word health out and just talk about structural inequities driving disparities. And when I say structural means that it's actually physically baked into policies and institutional practices, and most manifest in places in neighborhoods because we physically allocated people fewer resources in these neighborhoods based on their perceived value. If you're simple-minded like me, you just say that these are conditions that create consequences, and we spend a lot of time managing the consequences. In fact, you could describe most of the healthcare enterprise as damage control. And what we argue is that's absolutely necessary, but you have to figure out what's causing the damage. What are these conditions that we have some influence over? So we've argued that, it's not just healthcare. You see this in educational outcomes as well, that maybe we should focus a little bit more upstream. We've simplified upstream to narrative. And with this new president that we have now, he's actually quite expert at using narrative, a very hostile and white supremacist narrative, quite frankly, to shape policy, and then policy creates conditions. So we recognize that narrative begets policy, policy begets conditions, and those conditions are what allow people to either navigate a healthy life or to actually have to avoid a hostile terrain that has a great likelihood of reducing their life expectancy and their overall well-being. As I said, the secret to this is power. We have to build power in communities to be able to participate more effectively in political decision-making processes. That's what we've done in California. We've seen the impacts on health. We've seen the impacts on education. We've seen the impacts on criminal justice. And we're continuing to do that work all throughout California to great benefit. California is a very different place than the rest of the United States. Um, Healthcare costs live downstream. This is a very expensive way to manage population health. It doesn't work. Actual health lives upstream. Health is something that you invest in. Healthcare is something that is an expenditure. If you want to reduce the expenditure, you have to increase your investment upstream. I'm going to conclude there. There's a recipe for doing this work. We call it ABC. It's focused on building agency, or the ability of people to effectively shape their interactions with society, belonging, which is really the kind of the antidote to racism, and changing structural conditions, which is really our social contract. It's investing in universal health care, universal child care, paid sick leave, and a whole list of proven policies that have shown, not just in this country, but in virtually every other Western developed country, to improve the health of the underlying populations. I'm going to stop there and stop sharing and hand it back to Dr. Khan.
Great. Thank you, Dr. Iton. That's really, really fascinating. I really enjoyed the framework that you presented and how it compares upstream and downstream. I think that's something that we often don't think about at all. And I also appreciate the work that you did on the zip code. I'm a native of Cleveland. I grew up there. I actually did my residency there too, and University Circle, not too far from the Huff neighborhood, but actually not, as you pointed out, also not too far from Lyndhurst as well. So it was just interesting to know that within 2 miles, you've got these vast differences in life expectancy, upwards of 30 years. It's really amazing.
Yeah, it's really the difference between Sweden and Afghanistan in the same neighborhood, the socio-ecological equivalent.
Yeah, absolutely. If you don't mind, I just had a question I just wanted to follow up on. How do you explain the vast difference between average life expectancy of Canada and California? I think we think of California overall does a pretty good job, but to see really Canada that much higher, it's kind of really impressive. Is it social services? Is it something further, maybe more political? And what can we do kind of in the county to sort of get to that level, or the state?
Yeah, I will try to give you a short version of the answer, because this is really, something we could talk about for quite a while. So Canada has a whole host of policies. It has a strong social contract. I went to undergraduate in Canada for free. I didn't pay a nickel to go to undergraduate. I could have gone to McGill Medical School for free. I chose to go to Johns Hopkins for reasons that I'm not entirely sure of in retrospect, but I had to pay for that. But Canada invests in its people. It basically invests in the social determinants of health. So education is free. There's subsidized, parks and recreation facilities. There's good transportation systems. Obviously, you have universal health care, you have universal child care, you have universal paid sick leave, universal vacations for all employed people, employment benefits and rights that protect you when you have adverse occurrences in your life. The United States has none of that. And so you're kind of on your own. They refer to the United States as, you're on your own society. It's a yo-yo society. And there are other societies that are basically that make investments. And so California is still in the United States. I mean, there's a lot of policies that have been invested in California, but it's not Canada. You still have all these, it's much smaller number than most states, but you still have a lot of uninsured people. You still have a lot of people that struggle to afford a decent education, and certainly post-secondary education, to afford college. You certainly have, relatively, although California's done better than other states, relatively low wage, occupations where people essentially, we like to talk about the root cause of health inequities is really stress. It's chronic stress. And we create sort of stress incubators in our low income communities and even in our middle income communities where people are constantly worried about losing a job, losing health insurance, getting into a car accident, getting bankrupted. These are things that other societies, people don't have to worry about. And so that chronic stress, raises your cortisol and causes, diffuse cardiovascular injury independent of your diet and your behaviors. So we think that if we can reduce the burden of stress for people in society by investing in the things that we all know people need, we can actually improve their health. And that's essentially the story that we've seen internationally, where the countries with the greatest health actually invest more in social services and social benefits than they do in healthcare. We have the accent on the wrong syllable. We invest disproportionately downstream in healthcare, and we underinvest in social services and benefits.
Right? No, thanks. That's a great answer, and I agree with everything that you're saying, and it makes a lot of sense. I think we just need a separate type of framework in the U.S. about how we talk about these issues, because a lot of these things come up. All we've seemed to do is just throw money at the problem, but we're throwing money at the wrong end of the spectrum.
Yeah.
But yeah, thanks for that comment. I wanted to move on and welcome Corneliu Delogramatic. He is the Health Equity and Clinical Integrity Director at El Camino Health. Dr. Delogramatic is a trained vascular surgeon with over 15 years of hands-on experience at the bedside. Cornell's passion for health equity was ignited through his volunteering activity at Doctors Without Borders, great organization. He's a surgeon in complex conflict zones, including Afghanistan, Pakistan, and South Sudan, where he witnessed firsthand the dramatic impact of healthcare disparities. As the inaugural director of the Health Equity Department, he's dedicated to closing gaps in care and championing equitable access for all. He's also an active member of several local and national expert groups focused on health equity and quality improvement. Outside the hospital, Cornell is an avid science fiction reader, a regular volunteer around Bay Area food banks, and proud coach of his two sons' school soccer teams, where he celebrates their athletic triumphs and their learning moments. I've been through that before too. So Dr. Delogramatic, the floor is yours. Please, we look forward to your presentation. You are on mute.
Can you hear me well now? Thank you so much, Dr. Ken. Yes, I think we're more at the learning opportunities now with my sons and celebrating success.
Trouble with your sound.
Yeah, it's coming in and out a little bit, Dr. Delogramatic.
Can you hear me better now?
It's a little bit better, but a little bit spotty.
Let me see if I can change probably my my sound.
Okay, no problem.
How about now?
I can hear you now, right now. Right now sounds good.
Better.
Yeah.
Yeah, thank you so much. I want to say a big thank you to you and to Theo and to the Santa Clara Medical Association, County Medical Association for inviting me. You know, it's a privilege, first of all, to be on the same panel with Dr. Iton. I know if I told my story, but my work pretty much was impacted a lot by you, Dr. Iton. I know if you recall, in 2022, I was part of a health equity symposium at Stanford, and I heard your speech first time there. And it was just so impactful for me because pretty much it galvanized all the work that I did at El Camino Health after that. And I would never forget the words there that you repeated today about health equity is political and the policies are medicine. And I hold that very close to my heart, even in today's speeches that I have with my executive team and with my board. So a big honor and privilege. Thank you so much for all the work you do here. So a little bit about what I'm doing at El Camino, and unfortunately I don't have a slide, but I'll keep it pretty much very focused. Pretty much boots on the ground work. So we started our work around 2022, and I was very, very lucky to have a very supportive executive team at El Camino Health and a very supportive board of directors. And I think also at that time, one of the best, I would say, wins we had was that federal policies aligned with state policies, aligned with local policies. As you remember, Joint Commission released their white paper on health equity. Right in a couple of months, they made health equity the national patient safety goal. Leapfrog started to introduce their elements into the patient safety scores. And that was the perfect time for me to start all this work here at El Camino. We had a lot of trials and errors around our work in equity. And for many of you who practices at El Camino, you know we're a hostel located in I would call a very privileged neighborhood, and we serve very high income areas. However, I think it totally resonates with me what Dr. Iton said, that sometimes in these areas, in these geographic areas, the disparities are the most stark and the most acute. And when we started to do exactly what Theo said, when we started to look at our own policies, when we started to look at our own workflows and assess our own biases, we realized that there is a lot of work to be done. So we put a team together. We actually built a department, a fully dedicated department that will look into health disparities and health equity. And we started our work. Primarily, we looked at what the federal government will direct us to do, data collection, data stratification. However, as we were reviewing and looking in our disparities, we realized that there are work that needs to be done immediately as we go in parallel with all this data stratification and data collection. And the most important thing that we had to address immediately was those social drivers of health. And as you mentioned, pretty much all on this panel, that they constitute 80% or even more than 80% of a person's health outcomes. So looking at that, we wanted to take a little bit different, slightly different approach that was recommended in different conferences that I would attend and different places I will go and listen around the work being done regarding social drivers of health, which primarily directed a self-reporting method. However, here at El Camino, we decided that our problems are so acute that we wanted to be a very dedicated approach and very clinical-driven approach. So what we did actually, we engaged strongly with our nursing units, with our nursing leaders, and with our nursing executive team. And we decided that this screening is going to be very intentional, not left at, self-reporting kind of like level, but being done by dedicated nurses. And so it was not an easy deal to be done because, nursing workflows are already busy with a lot of clicking of the buttons and documentation and workflows and regulatory requirements that they have to fulfill every day. And so what actually we did was that we sat at the table, exactly as Theo said. We look at the data, and then we decided to make a trade-off. And one of the things we did, we actually optimized their nursing admission workflows. And so we look at what they're collecting so far, what is probably outdated, what is probably not needed anymore to be collected, or what else can be optimized so we can free up time and space in the electronic medical for this important work to be done. So we started to collect this data around December of 2023. It was challenging because it's a new process. It's a status quo change, and it's very uncomfortable. It is very uncomfortable for clinical staff to go and ask patients about financial insecurity. It is very uneasy for a person to go and ask about health instability. And of course, the first reactions were like, why we're doing that? And it seems a little bit off or it's a little bit strange. And the comment I made is like, you remember in 2005, 2006-ish, somewhere there when we were required as organizations to start collect data around substance abuse and alcohol screening. That was uncomfortable as well. But look at us today. I mean, these things are natural, normal things that every nurse, every clinician does thousands of times a day. So, of course, we went back to our roundtable, and what we decided to do actually to develop two scripts. for nursing staff and for medical staff that they can follow to answer these questions, and thus making this process a little bit easier. And so in a matter of a year, we actually increased our systematic review of and collection and assessment of social drivers of health from, I would say before that, pretty much being done by social workers from 5% to almost 90% in all our inpatient population. And so that was the first step. Of course, we didn't want just to collect the data for the sake of collection and to reporting to CMS. We want to do something with that data. And the first thing we noticed that about 2% of our population at El Camino suffers from one of social drivers of health issues. And we started to collect 5 domains: food insecurity, house instability, transportation needs, financial instability, and interpersonal safety. And so with exception of interpersonal safety, which is a very low number of patients that screen positive for, financial neglect, physical abuse, neglect, and so on. Pretty much for all other 4 domains, we had about 2% positivity rate in our population. And when I started to review these cases, they were really acute problems of patients who really suffer from hardship in terms of maintaining their housing status in this super expensive areas. We had problems with people who cannot afford to have a reliable transportation to come to our chemotherapy treatment and so on. So we immediately started to look at how we can collaborate with our social workers and how we can develop our infrastructure around providing support for this population. And I'll be honest with you, I couldn't believe how much support and how much engagement we started to get from our staff. I felt again it's going to be a very uphill battle, but the message I got overall was why we're so late doing that? We should have started to be doing this way years ago, which really became to be more uplifting for me and trying to achieve even more in this area. So for now, I would say I can't even tell you how many things, because it's a rabbit hole. You go into and you realize, oh my goodness, hold on a second. We were sending these patients with AVSs with expired or inexistent resources anymore. No one ever look at it to see, okay, the patient that I sent to that food bank, does that food bank even exist already or is gone? How about transportation resources? So start from work like this, where we had to review all our discharge summaries and discharge, instructions to make sure that the resources that we provide to these people are indeed relevant, and we're sending them to a right place, a place where they will not knock on the door and no one will open, with a more proactive approach where we work very close with Marie Bernard, with Sunnyvale Community Services, with our Los Altos food banks, with our, shelters around hospital to ensure that these patients are being addressed at the right level. We also, because of the collection of data, started to draw more information. So we started to understand that many of these patients would come to us multiple times during the year with the same issues, with the same problem, which many times is not medical in their nature. It's more social in their nature. So we started to establish some programs in that direction. So I would say that was an amazing work done around social drivers of health, which I feel was more impactful than rather just, data stratification, race collection, and ethnicity collection, and fighting in the meetings around, sexual orientation, gender identity, how we can classify these patients either straight or not straight. So that was very impactful. Although the work that is being done around race, ethnicity, there's a lot of things we did here where we start to look deeper into disparities at the level of our race and ethnicity and things like that. And of course, a lot of other work being done, like Theo mentioned, we look at our cultural competence care. We develop a lot of work around there. LEP, like Theo said, almost half of our population is of immigrant origins. So we did a lot of work around limited English proficiency. We deployed a lot of solutions on our floors around translation assistance and making sure that these people and their relatives are being addressed in this issue. By the way, the things around limited English proficiency actually came out of our quality council. That was the first voice that I heard from physicians saying, if you want to do something about health equity, look please in language barriers, because many times I go in the patient room, I talk to the patient, they nod the head, but I can tell you they didn't understand nothing what I said to them. So that kind of like also filled the work done there. And of course, as many of you know, El Camino is a very big hub for maternal and neonatal healthcare. So a lot of work is being done around our maternal disparities, and we're working very close with CMQCC and with Santa Clara Perinatal Equity Alliance, making a lot of great headwinds there. So that's pretty much like boots on the ground, a little bit of like how all this kind of like high policies are being applied at the hospital level. So thank you so much again for being invited here and for allowing me to talk a little bit about our work here at El Camino.
Great.
Dr.
No,
Khan?
yeah, thank you, Dr. Delogramatic. I mean, that's very interesting to hear perspective on the healthcare system side, and that perspective is really good. If you don't mind, I just had a question more on the sort of the physician side. Since your role started, what type of education has been around for specifically for physicians to sort of get an idea of health equity? And how has the engagement been, and what kind of future sort of partnerships with the physicians do you envision at El Camino?
So around physician education, primarily, I can say that physician was our main target. However, when we started to pursue a more systematic approach to cultural competency, I think cultural competency was primarily the first, I would say, equity element that we wanted to address at the level of education. And of course, we partner with a couple of solutions that we have where, you know, we provided education to the physicians. But I would say the most important education piece that occurred was driven by our, chief quality officer and chief executive, medical, clinical executives, to ensure in that period of time, 2022, 2023, that health equity is being a component of any presentation, any process improvement work, and is being reported at the level of quality consult. So I think that fueled a lot of self-education at the level of service lines and the level of medical department, surgical department to research and to work around these topics. It was a very weird time, I'll be honest with you. I'll go in this meeting and we'll be just silent because, let's say the chief of the stroke service line will look at me and we'll look at him and he'll be like, so what should I do? And the mission we had for the department was that, you tell us, you are a physician, you are at the bedside. What do you see from your perspective in your department to be a disparity? And the first sessions were very awkward, but I can tell you 2 years from now, you should probably come on one of our quality consults. Pretty much every presentation has a health equity component into it. And it's not anymore at the level of reporting. It's at the level of process improvement or performance improvement around this equity measures. I'll give you an example. Our anesthesiologist group and the HCAP communication scores and how they linked to the fact that, our communication scores are so low might be because of our, limited English proficiency population. Then we drill into data. We found out that that's exactly as Dr. Iton said, it's a correlation. We didn't know it's a causation, but we knew it's a correlation. And when we start to dig deeper into the problem, we realized that the instruction we give for these patients, especially for short surgeries, for outpatient ambulatory surgeries, guess what? 99% of them were in English, having about 40% of our population being either Spanish-speaking, Vietnamese-speaking, or Russian-speaking. And then how do you expect the person to be called back like press gain and saying, by the way, please rate the communication you had with physician if you never understood a word that the physician said or it was written on his summary. So that type of work where we see kind of like evolving in our organization, and super proud of how engaged our medical staff is.
Great, great, wonderful. Thank you so much. I personally look forward to seeing how El Camino goes forward, given that I practice there as well. So thank you so much. I wanted to sort of move on. So Theo, as the mastermind of this webinar, wanted me also present a little bit about my perspective, my personal practice perspective. And I wanted to do that a little bit today. I think, this is obviously my own perspective and a little bit anecdotal. But I would say that, health equity is not something that I was part of in medical school. They just don't teach this really in medical school. There's a lot of stuff they don't teach you in medical school. They don't teach you about insurance companies, health equity, a lot of different things. So I actually am also a graduate of the School of Public Health at UC Berkeley. I didn't have the pleasure of taking Dr. Iton's class, but I learned a tremendous amount there. And health equity was one of the things that really resonated with me. So I wanted to sort of give you my perspective as a neurosurgeon in Santa Clara County and what I've seen. And this is, again, just an anecdote, but I hope it just sort of fosters a little bit of a discussion. So I wanted to present a patient. I'm going to do this in the typical medical fashion where we present a case and sort of go through it a little bit. So, and this is all just recent. This is very, very recent. So this is a 54-year-old Black man. He has a past medical history of diabetes. He's on insulin, and he also has a history of hypertension. So he presented to a hospital in Santa Clara County for what's called diabetic ketoacidosis, meaning his glucose is out of control, his diabetes is not well controlled. His glucose was 951. So normally you want it below, 140 or below. So he's way over the limit. So he gets admitted to the ICU. But while he's in the ICU at the hospital, he develops onset of right-sided weakness and aphasia, meaning he can't even talk. So this was presumed to be a stroke, and he's giving TNK, and TNK is a medication you give through the IV to break open the clot and bust the clot. And then what part of the imaging, what happened more than anything, he had occlusion of the left internal carotid artery. So that's the main artery that supplies the left side of the brain, which is important for speech and also for controlling the other side. He was then transferred to my hospital, which is a stroke center, for further workup. This includes doing pictures of that artery and taking out that clot directly if possible. Upon his arrival, we talked with his girlfriend. His girlfriend states that he's been really stressed. He's not taking his insulin, and he doesn't believe in antihypertensive medication, so he's not taking his medication. So all these things are really a risk factor: stress, poorly controlled diabetes, and hypertension, a risk factor for having a stroke, which is what he had. So on the right is a picture of his MRI scan. This is an MRI scan that shows the area of the stroke. The stroke is really the area that's bright. So just to let you know, on MRI scans, right and left are reversed. So the area that's bright is actually on the patient's left, although we're looking at it on the right. So initially when he came in and they asked me to see him, he was awake and alert. And at this point, he's undergone his thrombectomy already, where they tried to remove the clot. They removed as much as they could, but he still had significant stroke here. But when I saw him, he was not talking, not really moving the right side, but still kind of awake and alert. And then around 10 p.m. or so, he suddenly becomes less responsive. And then we do another image where we got a CAT scan of his brain. And what it showed now is that his swelling is growing up tremendously in the brain. And the issue with the brain is that since it's enclosed in the skull, it can't swell out. So it swells in. When it swells inside of the brain, that's when you get more brain damage occurring. So I took him urgently to the operating room, and what I did in this case, I wanted to give his brain room to swell. So what we do actually is we make an incision and take off a piece of the skull, and that skull actually goes into a freezer, and we close up the scalp. And when we do that, we allow the brain a couple centimeters to swell out instead of swelling in, so there's less damage to the parts of the brain that are normal. So luckily, the next day, he became a lot more awake. He got extubated, meaning he had the ventilator taken out. He was taken off the ventilator. But then overall, he had, a pretty typical post-operative course, maybe a little bit longer, 5 days in the neurosurgical ICU, which is expected. But he spent a really long time on the floor. He wasn't able to get out of the hospital that quick. He had insurance, and he has insurance. He has Medi-Cal, and this is through the Valley Health Plan. But then when it came to transfer him out for rehab and for subsequent recovery from a stroke, given his insurance, there was only one and only a few skilled nursing facilities that actually takes his insurance, but it's not really high rated. But he really had no other choice. His girlfriend looked at it. His mother, who lives out of town, also looked at it. But they were going really the best thing that was option for him with his insurance. So I saw this patient in my office, I want to say about 2.5 weeks ago. I talked to them, how is it going at the skilled nursing facility? His girlfriend was there and his mother was there. And they said, frankly, he's getting very little physical therapy. We haven't seen a whole lot of progress. And the speech therapy is not really there. And when I see him, he's wheelchair restricted, he can't ambulate, and he can only say a few words like yes, no, and really that's about it. There's a lot of grunting. He can understand language, but he can't express himself. So he's got something called expressive aphasia. What I also find out is that when he's there, the family tells me, he only has 10 more days that he's going to have in the skilled nursing facility. I'm thinking to myself, well, he's unable to walk. When I ask him what the living situation is, he lives in the second-story apartment. There's no elevator in the building. How is he even going to go get up to his apartment? At this point, he's not able to talk. He's in no outpatient speech therapy has been arranged, and even the therapy that was supposed to happen at the skilled nursing facility never really happened. His mother lives out of the area. She lives in the Central Valley, and his girlfriend needs to work. She works, not too far from my office over here. So really, who's going to be with him? And the other thing is that he still doesn't have this bone flap back, and he needs to wear a helmet. So then what I want to do is I want to at least get things moving along, and I want to schedule him for surgery. Since the swelling is now gone, I want to put that bone flap back. But my dilemma is that his insurance is not contracted with my hospital. So I don't know how to get him in. And he can't have surgery really anywhere else because that bone flap is sitting in the freezer of the hospital. So I make arrangements to do it. This surgery was actually scheduled for today. And I started trying to get authorization for this patient last week. And only yesterday at 5 p.m. do I find out, listen, the hospital and the insurance company can't come to a letter of agreement. I need to cancel the surgery, right? So when we talk about sort of equity, this is sort of important. So what are the lessons learned? Listen, I think overall we did a great job with his acute care, the stroke team, the neurosurgery team. We saved his life, right? But look at his insurance status, his rehab access, his housing barriers. This is what's really shaping his recovery. And this also sort of goes on to what we've been talking about before, the sort of the social determinants of health, along with the medical care that he's getting. I think there's also a difference here when we talk about resource allocations in different hospitals, right? So we came to a hospital, one of the hospitals I've practiced at is a private hospital, it's well funded, but we have advanced imaging there, we have specialists there, we have a comprehensive stroke center. But at the hospital that he initially presented on, that's more of a safety net hospital. They have some services, but not the high level services. And the other thing we need to look at is like the low resource skilled nursing facility he was eventually sent to, right? And they want to send him home just after 4 weeks, after really a devastating stroke. So I think, what can kind of help? And these are just some thoughts I had put down. Obviously, I think if he had longer, higher quality rehabilitation, that would have made a really difference in his life and his sort of prognosis going forward. There should be an ability to have home modifications, right? He needs accessible housing. There should be a mechanism that say, hey, this gentleman lives on the second floor of a building. There's no elevator in the building. He needs some kind of housing, maybe temporarily, or maybe some accommodation within that building. I think there was really poor coordination between the hospital, the rehab center, and sort of the community resources, right? So the hospital has its own social worker. They help to get him to the skilled nursing facility. Once he gets to the skilled nursing facility, my office had a really hard time even arranging for an appointment for him to come and see me because there's nobody coordinating his care within the rehab facility. And then once he gets in the community, what kind of resources is he going to have to get further care and sort of coordination of his care? I think insurance reform needs to happen, right? We need to be able to ensure that the care of the acute care is not only covered, but also the post-acute care, which is also just as important. And again, he has insurance, but I think you all agree with me that he is clearly underinsured. His insurance is not letting him go to a rehab center, and it's not even letting him get the second surgery that he needs. This is a major, major problem. So what are some potential solutions? Just throwing this kind of out there. We need, for this specialty and this patient particularly, programs linking stroke survivors to affordable rehab and social services. Maybe tele-rehabilitation is not a bad idea, or even have group-based rehab centers. Maybe you could bring the cost down overall. Maybe more virtual speech therapy, physical therapy, especially for patients who have mobility barriers. So now, if he does go home, he's going to have a really difficult time going to an outpatient center. Is there something we can think about more around doing virtual visits, right? Patient navigators, community health workers. I think we need more of these. We need to help patients and families navigate insurance, which is really difficult, rehab and housing. And honestly, my staff, we try to do a really good job navigating all this, but the coordination is really hard because we don't have anybody on the other side, say at the skilled nursing facility, help to coordinate that. And we really need to improve this post-discharge support. We do a little bit, but we don't do a good job. Home modification, I talked about, maybe we should have some insurance coverage so around that area. And I really think that overall, we just need expanded coverage. And this is a little bit of the policy and advocacy that we do around rehab and long-term care for stroke survivors. So call to action. I think we need to recognize the outcomes after neurosurgery are really shaped by a lot of social factors. Surgery can go great. We can do a good job. But we really need to advocate in this patient's especially case for is equitable rehab access, stronger community partnerships, and really patient-centered policies. So I just say, just to remember that saving a life is only the beginning. Equity really does mean ensuring a meaningful recovery as well. So that was kind of just, like I said, an anecdote. I sort of wanted to bring that up and discuss that with the, at least share that with the group a little bit. And I just wanted to open up to the floor now if anybody had any questions. I particularly just wanted to ask one question to the group, and maybe I'll just jump right in. I think we're dealing with really complicated policies and governments and frameworks, and there's a lot of historical bias, especially in the United States. But if I could ask my panel, maybe each of you to comment on, if you were to have one wish of all the things that you could do, especially at the state or the county level, what do you think could make the biggest difference for equity in the healthcare access we have in Santa Clara County? Let me maybe start with Dr. Iton, if you don't mind.
Sure. I just want to comment first, Dr. Khan, that was a great story. I mean, that really was very illustrative. Thank you for sharing that. So as you probably can imagine, I've thought about this quite a bit. And I'm actually in the process of writing a paper right now with some colleagues on this issue of, our healthcare system is so fragmented, and because it is largely it's a system that's built around financing care, not actually delivering quality care. And so the incentives within that system are to essentially avoid risk, avoid financial risk. And the other problem with our system is that there's no local control. So the case that you just described would have benefited from, take a central entity like the public health department that could help essentially manage this care in the community with community health workers and other specialized nurses that could do home visitation, other environmental specialists that could work on the housing modifications, putting support bars in the shower and ramps, etc. But there's no centralized local kind of function, as there is in other countries. And even in the United States, healthcare used to be a very locally managed and controlled industry, and really it essentially became all about the financing of healthcare and not about the actual delivery of care. So health insurance companies have shaped the system according to their needs, which is to reduce their financial risk. But doctors and patients have relatively little control in shaping the actual system design that would deliver the best care and make the kind of decisions, like in the case of the patient that you described, would have obviously both saved money and improved his health outcomes. So it feels late in the day to be recommending these policy changes, but for I and my colleagues who are writing this paper, having some sort of a local accountability across the entire healthcare system that's integrated with some actor that's representing the community side of the care that's delivered, that helps doctors like yourself who are trying to do the best job they can, but have no ability to shape how this patient navigates, the world outside of the four walls of the hospital. So that's what we're talking about, and I hope we can get to that someday somehow, but we've moved so far away from that in terms of what our healthcare system is that it'll be a long trek back.
Oh, thanks. I really love the answer. It almost seems like you're saying something might be kind of achievable, because it's not like you're asking for a big reform of the whole medical system. I mean, at least at the public health level, at the local level, this could be attainable, but the resources need to be in the right place.
Yeah.
Yeah, great. Thank you. Thank you. Theo, I wanted you to sort of comment here a little bit. So what policy changes do you think, from your perspective, after the research and the wonderful presentation you gave, and would be the biggest difference for equity and the healthcare access of the county?
That's a great question. Unfortunately, I haven't had the significant work experience that people like Dr. Iton and Dr. Delogramatic have had, but I think less of a policy change that I would love to see as my one thing, and more, I would love to see a cultural change. We know that it takes a lot of different people to advocate for change, but if we have a culture that expects and values equity, I think that those changes happen a lot faster. So I don't know that I can think of a silver bullet other than like have I would love to see our attitudes around health and equity be changed in
Yeah.
that respect.
I think that's a fantastic answer. I mean, that's also something that I think just takes a little bit more education and work on our part. And like I said, in medical school, they don't teach you this. I really got an understanding of all this really in my MPH program. So thanks for that answer. And then Dr. Delogramatic, I wanted you to just comment on the same question.
Yeah, I mean, being every day in healthcare at the hospital level, I think access to care, finding new opportunities for us to get that access to care more affordable and easier to get for this population who suffer with this volume of, increased social drivers of health problems. I was like reflecting on your case. I mean, your patient's even lucky that he got his first surgery. Many patients, I don't know how many of you know, but the latest statistics showing that for a patient in the South Bay area to get his primary care physician appointment takes about 2 to 6 months.
I believe it.
That is unseen. It's something that is becoming unbelievably luxurious for you to go and see your primary care physician. So at the level of county, absolutely, I would say, finding that bright mind, thinking out of the box, how we can get this access to care more affordable and more efficient would be something that I would recommend. At the federal level, I think I totally agree with you, Dr. Khan. I was not taught in medical school about disparities. I never had a curriculum where we talked about disparities or looking into, equity or looking at pathologies through equity lenses. So I think that is something that I would like to see in graduate and postgraduate kind of like education systems to happen here in the United States.
Yeah, I think that's a great suggestion. Okay, well, that's going to sort of wrap up our webinar. I wanted to thank everybody for our panelists for being with us here today. Theo, great work. Thanks for organizing us. Dr. Iton, really appreciate your thoughts and look forward to what kind of great work you're going to do. And also at the health system area, Dr. Delogramatic, really thanks for all that you're doing. I also want to give a big shout out to Emily Corin, who's helped organize this in the background. So Emily, lots of thanks. And again, thanks to everyone for watching and attending.
Thank you.